Antiparkinson drug. First, you have to understand what is Parkinson. Parkinson is nothing but imbalance between dopamine and acetylcholine, which means decreased dopamine and increased acetylcholine. There's imbalance. There's a decreased dopamine and increased acetylcholine. So, which drugs we could use? Very simple, to increase dopamine or decrease acetylcholine. That is what happening. In practically, how a Parkinson patient comes, he has trap, he has tremors. T means trap, it's a mnemonic, it's a trap, tremor, rigidity, akinesia, and postural instability. So those, it is a mnemonic, it is not actually belonging to here. Due to a sake of completeness that I use here, trap, tremor. Which kind of tremor? Pill rolling tremor, 3 to 5 hertz. And patient will have rigidity, and patient is having bradykinesia. The whole mark of Parkinson is bradykinesia, slow movements. That is Parkinson. And they have a narrow based gait. All right. So that is that I have to tell about Parkinson as a disease. But for the pharmacology, you just have to remember there is decreased dopamine level and there is increased acetylcholine level. Either we could increase dopamine or either we could decrease acetylcholine. Most of the time we increase dopamine. To decrease acetylcholine, we use anticholinergic drugs. If patient is psychotic, we could mainly use these um, anticholinergic drugs. Otherwise, for normally primary Parkinson, we use dopaminergic precursors. As an example, first very famous dopaminergic precursor is levodopa. Next, we could use dopaminergic agonist. As examples, bromocriptone, ropinirole, pramipirole. And dopamine decarboxylase inhibitors, carbidopa. Monoamine oxidase B inhibitors, selegiline, rasagiline. Catechol O methyl transferase inhibitors, tolcapone, entacapone. Dopamine releaser, amantadine. In here, amantadine is an antiviral drug, but when in history, when they use amantadine, the Parkinson patient was improving his symptoms. That's why, as a dopamine releaser in antiparkinson drugs, we use this amantadine. It's actually antiviral drug. And anticholinergic drugs, we could use benzhexol, benztropine, and biperidone. Also, we could use antihistamine like diphenhydramines. So, in this picture, all the drugs and all the mechanism you could see. Levodopa, we begin from levodopa. Levodopa is a precursor. No? Levodopa cross blood brain barrier, it convert into tyrosine and it will again convert into L-dopa. L-dopa convert into dopamine. Then they act on dopaminergic receptors. That is what mechanism of action of levodopa. It's a precursor. It is a not direct dopamine. It should cross blood brain barrier and it should convert into dopamine, because dopamine has less ability to penetrate blood brain barrier. That's why you precursor. But there's a DDC, it's dopamine decarboxylase. It will degrade levodopa into dopamine in the outside of the brain. So when you give levodopa, we usually give with levodopa plus carbidopa or DDC inhibitor, because we need precursor, not the dopamine, because precursor cannot easily penetrate blood brain barrier. So we don't need to convert levodopa into dopamine in the blood. Next, it also catechol O methyl transferase COMT. Also they convert into levodopa into 3-CMD. So for catechol O methyl transferase inhibitors, we use tolcapone and entacapone. Either you could use levodopa plus carbidopa or Either you could use levodopa plus tolcapone or entacapone. And here that you could see in the this is the receptor, and we could use drugs that directly acting on the receptor as well. Those are bromocriptine, rapinirole, pramipexole. Again, these here MAOB, they convert it is into dopac, and to decrease this conversion we could use selegiline and rasagiline. And in the neuromuscular junction, to decrease this acetylcholine we could use anticholinergic like benztropine, biperidone or trihexyphenidyl or benzhexol. So this is the path PCO and drugs. And normally in therapy, normally for the levodopa, for the levodopa, good there's good response in primary Parkinson. So normally first the best drug for Parkinson is levodopa, but it is not given alone. And mechanism of action, it cross blood-brain barrier and convert into dopamine, usually given with carbidopa, entacapone or tolcapone. These are the drugs. I mean, in pharmacy, they have co-careldopa or co-beneldopa. These are combined drugs with levodopa. Side effects system wise: GIT, anorexia, nausea, vomiting, cardiovascular, arrhythmia, tachycardia, postural hypertension, dyskinesia, behavioral one, anxiety, confusion, depression, hallucination. Actually, for the Parkinson, there is on-off phenomena. On-off phenomena is nothing but when you give the drugs after 1 hour, patient will be very good. I mean, the condition of the patient will be improved. Like normally in the Parkinson patient, he's very slow moving. He cannot do things very quickly. Like they have mask pace, they have gait, they have tremors. They all will be reduced after 1 hour you give the drug. But after sometimes 2 to 3 hours, that from the peak, again the drug concentration in the blood will be reduced. Again, off phenomena occur. Now patient condition worst. So that is what it is on off phenomena is. When initially you are giving the levodopa, patient condition is very well improved. After 2 to 3 hours, it will be worsened. But again, even though we give the drug, because the Parkinson there is no a complete treatment, which means you cannot cure Parkinson. You have to remember that this is actually, as long as the patient is alive, we try to improve the quality of the life of the patient. So that is what is happening. Even now, there is no cure for Parkinson. You have to remember. Also, we could use bromocriptine. In this picture, you saw that bromocriptine is directly acting on D1 and D2 dopaminergic receptors. They are D1 and D2 partial agonists. Indications: normally you could use levodopa plus bromocriptone for refractory Parkinsonism, or if patient does not tolerate well the levodopa. And bromocriptine also you could use in hyperprolactinemia. Hyperprolactinemia is an endocrine disease. In hyperprolactinemia we use bromocriptine as well. So this is all about Parkinson. If you can understand this picture, what is happening here, you could understand whole pharmacology of Parkinson. So again, remember, which is the best drug for Parkinson, which is the best drug that respond to Parkinson is levodopa. Which two brands? Co-careldopa, co-beneldopa.